Hello, my name is Ifeyinwa Okeke, and I will be presenting the argument for the placebo group. Irritable bowel syndrome is a chronic and often disabling functional bowel disorder, which is characterized by abdominal pain and discomfort in the absence of any structural or biochemical abnormalities. Emerging evidence suggests that distinct pathophysiological disturbances may account for the symptoms, and IBS is unlikely to be one disease or merely a psychiatric disorder. IBS has been traditionally thought of as a brain-gut disorder in which susceptible individual with genetic predisposition, exposure to environmental factor, abnormal stress response, pathophysiological distress, infections, or inflammatory responses may alter intestinal permeability and result in IBS symptoms. Even though there are evidence supporting the use of FDA-approved pharmacotherapy in the management of IBS, but placebo treatment can significantly influence subjective symptoms, and the response rate to placebo in IBS treatment trial is 30 to 40%. So the question is, pharmacotherapy or placebo, which one matter? Mind over matter. The debate regarding placebo intervention compared with diet or pharmacological intervention for the treatment of irritable bowel syndrome continues. So which therapy is best? Filk et al. 2017 performed a rigorous systemic review and meta-analysis of randomized placebo-controlled trial for the treatment of IBS. The mean age range is 31.6 to 45.5 years. The N equals 6. Mean treatment duration is 8 weeks to 3 months. Among the 6 trials, the placebo interventions were psychoeducational support or general support, and the therapy arm consisted of cognitive behavioral therapy, CBT. Mindfulness placebo response rate are for improvement of IBS symptoms severely from baseline was 41.1%, which was comparable to 37.5% with pharmacological therapy. In a meta-analysis, 47% with medication plus dietary fiber, 40.7% with medication and alternative medication, and 42.6% with complementary medicine. A key point of this meta-analysis was that placebo response appeared to be optimized when the patients were provided with optimistic and realistic expectation and their IBS intervention. The means of providing optimistic and realistic expectation to the study subject ultimately related to empathic, longer and more frequent interaction with the prescriber. Filk et al. Suggested that from a clinical perspective, a high PRR and a good treatment response were equally positive outcome. So the combined PRR associated with the psychological intervention provided a greater clinical relevance. This theme of enhancing placebo effect by full disclosure of intervention to study subject is supported by Kapchuk et al. In 2017. At day 21, IBS Global Improvement Scale score significantly improved in subjects who received open-label intervention compared with no therapy. During screening and prior to randomization, the potential subjects were told that placebo were shown to provide self-healing properties. Additionally, provision of a positive outlook can help patients look for ways of reducing stress, anxiety, and panic attack to help calm nerves and thus reduce IBS symptoms. So the question is, is secrecy necessary for placebo effect? Patients with IBS felt better after knowingly taking a placebo, suggesting that secrecy of giving patients dummy pills may not be necessary, Harvard researchers report. In a trial involving 80 patients with IBS, investigators from Harvard Medical School OSHA Research Center with Beth Israel Deaconess Medical Center in Boston found that the so-called placebo effect may be more than just thinking that you're taking real drug. Placebo patients experience greater symptom relief, according to Ted Kapchuk, ODM, an associate professor of the Harvard School of Medicine and director of Asian Medicine and Healing Program, and colleague randomly assigned patients to one of two groups: those who were informed that they were to take placebo pill twice a day and those who received no treatment, but had the same quality of interaction with the healthcare provider. In fact, the placebo pills were given out in a bottle labeled placebo and described as placebo pills made of an inert substance like sugar pill that have been shown in clinical studies to produce significant improvement in IBS symptoms through mind-body self-healing process. After 3 weeks of treatment, nearly twice as many patients taking a placebo reported improvement in their symptoms as those who received no treatment, 59% versus 35%. Moreover, patients taking a placebo doubled their rate of improvement, meaning that they felt better more quickly, at most the same rate if they had taken actual medication for their IBS. Midway through the study, side effects were reported by 3 placebo patients. By the end of the study, 5 placebo patients reported side effects such as respiratory infection, pain, runny stool, and rash. Kapchuk and his team questioned the ethics of prescribing a placebo without the patient knowledge and designed their study to determine whether placebo effect would occur when a patient is informed that they are taking a placebo. Why a placebo might help reduce symptoms isn't entirely clear. They told the patient that they didn't have to even believe in the placebo effect. Nonetheless, these findings suggest that rather than mere positive thinking, there may be significant benefit to the very performance of medical ritual. Placebo may work even if the patient knows it is a placebo. So the question now is, in IBS, placebo versus diet or pharmacotherapy? Thank you.